أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. صدق الله العظيم.
Good evening, everyone, and welcome to tonight's grand round by MSAUN-KNH. My name is Khalid, and I'm a fourth-year MBChB student and current mentorship coordinator at MSAUN-KNH. I'll be moderating this evening's session, which will be on traumatic brain injury. Tonight, we're privileged to have a highly educational and engaging session. The case presentation will be delivered by Saddrudeen Ali, a sixth-year MBChB student. Following the presentation, we'll have a case discussion led by Dr. Mohamed Omar, a fifth-year resident in neurosurgery and deputy chief resident at the University of Nairobi. Dr. Omar holds an impressive academic and professional background, including a BSc in medical physiology from the University of Nairobi, MBChB from the University of Nairobi, an MSc in medical physiology, and is currently pursuing an MMed in neurosurgery. He also serves as a tutorial fellow at the Department of Anatomy and Medical Physiology at the University of Nairobi. And he's a tutorial assistant at the Department of Biomedical Sciences at Aga Khan University. Without further ado, we are going to begin the session with a presentation from Saddrudeen.
Thank you, Khalid, for giving me the opportunity. Thank you all for attending, and I'd like to also thank Dr. Mohamed for taking his time for moderating this session, and he's going to do the case discussion. So I think I can start. Are you able to hear me, Khalid? Can you confirm if you're able to hear me and you're able to see my screen?
Yes, we can hear you and see your screen. You can proceed.
So, thank you. So my case discussion today will be on traumatic brain injury. So biodata, the patient's name is FWA. He's a 42-year-old male, admitted at Ward 4C at KNH. He resides in Kawangware, Nairobi, and he's a Jua Kali worker. He was admitted 1 week, 3 days ago via the outpatient surgical clinic, and his presenting complaint was headache for a week, and he has no known chronic illnesses. So his main complaint was headache for 1 week. So the patient was previously well until 1 week and 3 days ago, when he was involved in a high-impact road traffic accident on the morning of Saturday, 27th April, at approximately 6:30 a.m. At the time of the incident, he was riding his motorbike along Gong Road on his way to work, and he reports that he was hit on his right side by a high-speed 33-seater matatu following the impact. So he lost control of the motorcycle and was ejected, falling into a roadside ditch, landing predominantly on the left side of his body and hitting his forehead against the concrete surface. He was wearing both a cap and a helmet at the same time, and he recalls that the helmet broke upon impact, and he immediately lost consciousness. He estimates the duration of unconsciousness to be approximately 3.5 hours, regaining awareness at around 10 a.m. Upon regaining consciousness, he found himself lying in muddy water, confused and experiencing pain in multiple body parts. At that time, he reports no otorrhea, no rhinorrhea, no periorbital edema, no focal neurological deficits or diplopia at that time. Additionally, he experienced hematemesis of approximately 250 ml of fresh red blood occurring shortly after the accident, not associated with any palpitations, dizziness, or syncopal episodes. He also reports low abdominal pain around the umbilicus that was sudden in onset, constricting in character, continuous and non-radiating. There were no clear aggravating or relieving factors, and severity he rated the abdominal pain as a 7 out of 10. It was also associated with difficulty in walking because of the pain. The patient denies alcohol or drug abuse, or any fatigue or drowsiness at the time of the accident, and he reports that the road conditions were favorable. So he was subsequently assisted and transported by an ambulance to St. Peter's Health Facility, arriving at around 10 a.m. At St. Peter's, the following were done. Initial assessments, including a chest X-ray, was done, an abdominopelvic X-ray was done, an abdominal ultrasound was done, and the forehead lacerations were sutured. He was catheterized for urinary output monitoring. IV fluids were initiated for resuscitation and maintenance. No cranial CT was performed at that time. No blood transfusion was administered, and he was admitted for 3 days at the facility and discharged home thereafter. So approximately 2 days following his discharge from St. Peter's, the patient began to experience a progressively worsening headache. He describes the headache as global in distribution, with a gradual onset, and was persistent and continuous in nature. The pain, the headache was exacerbated by motion or movement. Although partially relieved by analgesics, it still remained significant, with a severity of 7 out of 10 on the pain scale. The headache was associated with visual disturbances, including blurry vision and episodes of photopsia, where he described seeing stars in both eyes. He also experienced accompanying dizziness and reported episodes of intermittent low-grade fever. And importantly, he did not report any associated neck pain or stiffness, photophobia, focal neurological deficits, or convulsions. The patient also reports no prior history of fever, night sweats, or unintentional weight loss. Due to the worsening nature of his symptoms, the patient then returned to St. Peter's Hospital, where he was reviewed and referred to PCA Hospital for further neurological evaluation and imaging. At PCA Hospital, a CT scan of the head was performed, and consequently, he was then referred to KNH for specialized neurosurgical management. So he presented to the KNH outpatient clinic around 2 weeks ago, where he was booked for a repeat cranial CT scan to evaluate the progression of the suspected bleed. The repeat CT scan confirmed the presence of an intracranial hemorrhage, which necessitated urgent surgical intervention. He was then taken to the operating theater, where he underwent evacuation of the hematoma. The patient is currently 2 days post-op following neurosurgical evacuation of an intracranial hematoma. He now reports that his headache has completely resolved, with no recurrence since the procedure. He reports no neurological symptoms, including weakness. There is no numbness, there is no visual changes or altered mental status, and has not experienced any post-operative complications such as an infection, wound infections, or seizures. He is feeding well. He currently has adequate oral intake. He is ambulant without assistance and remains pain-free. He is currently awaiting medical clearance for discharge. So for his past medical history, he has had one prior hospitalization at St. Peter's Health Facility after the accident, and his second hospitalization is the current one, where he was admitted at KNH. He denies any history of hypertension, diabetes, or other chronic illnesses. No prior surgeries apart from the recent procedure. The patient has no known drug or food allergies. There is no history of previous trauma or fractures. There is no history of blood transfusions. So for his family and social history, he's the firstborn in a family of 2, all alive and well. His parents are all alive and well. The patient is married. He has 4 children, 3 boys and 1 girl, all of whom are also alive and well. His wife has a history of end-stage renal disease and has been on regular dialysis since 2020. He reports no history of alcohol consumption. He does not smoke cigarettes, but he occasionally smokes bhang. He has active SHA cover. So for his review of system, it was unremarkable. For his CNS, he's currently neurologically intact, he's oriented, and his headache has resolved. So for his cardiovascular symptoms, for his cardiovascular system, he denies any associated cardiovascular symptoms. There is no chest pain, palpitation, or syncope. For his RESP system, there is no cough, there is no associated dyspnea or chest discomfort. For his gastrointestinal system, he has had a history of hematemesis post-trauma, but currently he's doing well and tolerating oral feeds without any nausea or vomiting. For his genitourinary system, he was catheterized post-accident. Currently, he has no catheter. It has been removed, and currently he's voiding well. For his musculoskeletal, he fell on his left side of the body where he had experienced some pain after the trauma, and currently it has resolved. In the skin, he has some healed sutured forehead lacerations. For his ENT, there is no rhinorrhea or otorrhea, and there is no lymphadenopathy, no rashes. So in summary, FWA is a 42-year-old male patient who presented with a 1-week history of headache following a road traffic accident. He lost consciousness for approximately 3.5 hours and had an associated hematemesis and abdominal pain, but no focal neurological deficits or signs of basal skull fracture. A CT scan revealed an intracranial hematoma. He underwent barrel drainage and is now 2 days post-op with no fever, no signs of surgical site infection. His headache has resolved, currently stable. He is ambulant and is awaiting discharge. So on general examination, the patient was sitting upright in bed, alert and oriented to time, place. Yes.
Hello.
Yes, doctor.
Sorry. So this is Dr. Omar. I was wondering if it's okay so that we can make at least take gaps in between. Is it okay we can have a discussion on the history and then we take up, then after that you can continue with the examination so that people will be just focus on the history, see how to improve it and then pick it up from there.
Okay, doc. The floor is yours.
Okay, thank you very much. So I think number one, right from the outset, you have a very well put history, covered all the important areas that are needed. And it's very comprehensive. For all the audience members, I hope you have taken note. And the aim of you guys for this exercise is to be able to have that history and be able to get it within a period of 10 minutes or so when you're doing your long case. So kudos on that. Now, there are a few gaps that I want to just maybe have a discussion and point out. So I'll go step by step, especially with a focus on the issue of traumatic brain injury or review of a patient who has been involved in a road traffic accident. So Doc, just please go back all the way to, yes, okay, biodata, that's fine. Normally for, there's something I want to add there. Thank you. So for patients who, especially are neuro patients, you're lucky that you found a patient who was able to give you a history. A good number of patients in neuro, almost more than 70 to 80%, they would be confused or they were not able to give you a good history. So it's always paramount and important for you to include, in case there's an informant who gives you the history together with the patient to give you corroborating information. The reason being is, number one, they will either have a very good chance that they are not able to remember, or two, they will give you information that is not right. So it's good to include informant, especially when taking a history from a patient. If there is no informant, then just say the history was given by the patient and there was no informant to corroborate the history. Then the other thing I like also adding here for neuro is the handedness of the patient. It's quite important, whether the patient is right-handed or left-handed. The reason is because we already are looking at, that hemisphere that is dominant in the person. It will help us know the long-term prognosis of the patient. So that was good, apart from those two additions. Now, the other thing that I picked out, Doc, was in your date of admission, there was a bit of confusion, especially with the timelines. There was an area where you are saying 2 weeks prior is when he was admitted. Then here, the date of admission was 1 week, 3 days prior. So I would just like us to focus on the specific timeline. So that is good. Now, biodata, just go back. Biodata, chronic illnesses, none known. That is not part of the biodata of the patient. So residence, occupation, age, sex, initials, I think the rest are acceptable. So that's fine. So just maybe those two additional points. Now let's go next to your chief complaint, which is good. Now for patients who present with traumatic brain injury, for neuro, it's quite, I would say, almost straightforward. Neurologically, there are about 6 or 7 specific chief complaints that a patient can present with. The chief of them being you can have a headache, a patient can present to you with convulsions, a patient can have what is it called, otorrhea or rhinorrhea, which is either bleeding from the nose or from the ear. A patient can also have loss of consciousness, especially when they present to you in the acute setting. In this particular setting, you are reviewing the patient post-operatively, which is fine. So the headache was what was the patient presented with at that particular time. The other thing is that you can have, so I've talked about a loss of consciousness, convulsions, headaches, otorrhea, rhinorrhea. Amnesia is also another big thing that a patient can come with in neuro, or someone who has brought them will represent them with neuro, or like that history of, having been involved in a road traffic accident. So like for you, the main one that you picked here was headache. If the patient had presented to you, for example, at St. Peter's, you would also have elevated loss of consciousness as part of your chief complaint. And the duration is very, very important, which you've been able to put in. Again, the timelines have to corroborate. If it's 1 week, 3 days, it's the same, so that your chief complaint presents or tallies well with the duration of since the illness has occurred. So let's move to the next slide. So I think everyone has got me on that. So there are about 6, 7 chief complaints, and then you break it down. Now, history of presenting illness, I think this has been quite adequately covered. For me, at least, you presented the scenario of how the incident occurred and the date at which it occurred. Especially with regards to matters of traumatic brain injury and road traffic accidents, the main issue that you have is that you have future lawsuits that can arise, especially, for example, between the matatu rider and also the guy for the border. So those are things that you think about. Now, you described the scenario. What I was really just a bit interested in here is that, especially on Gong Road, because I live on that road, is that a patient for 3.5 hours no one was able to respond to him. That is a bit interesting. Most likely, the patient, when he was giving you that information, he did not know about the well-wishers, because I saw that at some point, at 3.5 hours later is when he found himself at St. Peter's. So there was some bit of contradictory information at that point. But overall, I think I liked it. You brought out the issue of otorrhea, rhinorrhea, periorbital edema, focal neurological deficit. Yeah, that's the other one in terms of weakness on one side. So that's the other thing that you put up. So let's go to the next slide. So here, we also had the lower abdominal pain and the hematemesis, which is a patient who has got multiple injuries in different organs. So I liked how you put it. I think to the audience members, you can see that Saddrudeen has done a very good job with the low abdominal pain. It's very easy, especially when you're in an exam setting. You have a complaint, then under the complaint, you're able to clearly categorize the findings. So you can see the timing, constricting in character, continuous and non-radiating, no clear aggravating or relieving factors, severity rated at 7/10. So that's fine. So I think we can move to the next one. Now, so this is what here we call the cause of illness. Now, I would want us to slightly change our line of thinking. There's nothing wrong with how Dr. Saddrudeen has presented, but Dr. Saddrudeen, when you listen to his history, it's almost he's presenting verbatim what the patient was telling him. So for you as clinicians or in the medical field, what is important to you is to be able to pick out the relevant things that the patient will tell you, because patients will generally tend to tell you many things. What I want to put out to the audience here tonight is that what is important to you might not be very important to the patient. And what is important to the patient might not be as important to you. It's probably important, but not as important. Case in point, for example, let me give you an example. You have a patient that comes to you in clinic and they've probably been to 2 or 3 different doctors, and to them, they want to show you the impact of how much effort they have done to try to resolve their own medical problems. So they'll tell you, I went and saw such a doctor, Dr. Saddrudeen, then I saw Dr. So-and-so, Dr. So-and-so. But to you, all those things are not as relevant as compared to description of what symptomatically the patient has. So in terms of presenting the HPI and etc., my advice would be this way. We have our chief complaint. The next slide should be able to discuss in detail the chief complaint that we have. So we have a headache. We go through Socrates for the headache. Then immediately after we go through Socrates of the headache, we have a slide that is talking about important positives and important negatives. So for example, important positives here would be that we have a headache that is associated with a feature of a raise in the cranial pressure to show that there's increased pressure in the brain. So we're talking about things like associated blurry vision, which I think Doc brought it out later on. We're talking about issues of diplopia, features of nausea. We have features of, vomiting, that even a patient is not associated with eating a meal. So those are the important things that I would like us to present. So those are your important positives. So as I told you, when you're talking about in a scenario of a neuro patient, you have your biodata. You're presenting complaints, you can have 2, 3, or 4 of them. The main ones, the other ones, you can be able to see how to merge them together with that. Then the next slide that I want us to come up with is important positives, which is positive things that are part of the history, but are not strong enough to be elevated to chief complaints. Then from there, you go to important negatives. So important negatives would be things like convulsions. Did the patient have convulsions or not? Did the patient have any focal neurological deficits or not? Was there weakness on one side of the body? Was there drooling from one side of the mouth? The issues of the rhinorrhea, was there bleeding coming from the nose? Was there bleeding coming from the ear? So those are going to be important negatives. From a neuro perspective, those are really, really important things compared to the follow-up of how the patient is. Then after that, we have a slide which is going to tell us about the cause of illness. Cause in this case being COURSE, like mwelekeo ama vile ugonjwa mgonjwa amekuja nayo. Now that is where we go through. The patient was taken by ambulance, taken to St. Peter's, seen there, admitted for 3 days, subsequently discharged, then came back, went to PCA Kikuyu. From PCA Kikuyu, did a scan, and then referred to KNH for further surgical management. So that is the cause of illness, which will take us about 1 slide or thereabout. But for the patient, when they're talking to you, to them, they'll tell you, oh, I went to this hospital, I went to this other hospital. But to you, it's not giving you the meat of what you want to point out. I don't know if I'm making sense, Dr. Saddrudeen, in my discussion.
Yes, Doc, yes.
Yes. So what you have done is very, very good. But I want us to highlight, we want like what is giving red importance. In this case, the red importance is the chief complaint, description of the chief complaint, where it is, what are the associated important positives, then what are the associated important negatives. Then after that, we come to the cause of illness and the circumstances of surrounding the cause of illness. Then after that, now we proceed to the past medical surgical history. I hope I'm making sense. Then I will just take 1 or 2 questions at the end of the history discussion point. So I think you did this very well. And then remember, each particular chief complaint that you have given, you have to describe it in detail. If it's focal neurological deficits, is it upper limb, lower limb, one-sided? Is it both lower limbs? Is it paraplegia, upper, lower? Headaches, Socrates, the headaches. What else? Seizures. Seizures, make sure you describe it in 3 phases. There's pre-ictal phase, ictal phase, and post-ictal phase. So always I want you to be that detailed when you're describing for a neuro exam. So we can move to the next one. So just wait, I want to just see, there's something else I had pointed. I wanted to pick out, I've even seen in the question, it was there. Go back, Doc. Go back. Okay, so this is fine. Just go back. Was there anything else before this? Okay, this is fine. So next slide. Okay, excellent. So I think just let's take cognizance of this. And for us, especially when taking a history, I would want us to be chap. Like this slide, the way that he has put it, you almost take a screenshot of it and store it in your mind. So that when you're taking the history, remember time is limited for you, especially in the long case that you have. And all these slide questions that you have on these different pointers, you've asked it in one go to the patient. Issues of allergies, issues of trauma, previous blood transfusion, so that you're not asking one thing, then you record, because you also need to find a way to save time. So next slide. So this is family social history. In this particular point, a good number of neuro patients, most cases would also be inebriated. So you need to have that clearly coming out in the history, which is we'll discuss also in the general examination. So next slide. So now here, the other thing I would just maybe point out, because I also see there's a doc was asked on the Songok, I think has asked on the chat group, because this is primarily a neuro exam, so we don't expect to review again systems in the CNS. So we really would eliminate the primary focus over here. And then also, I think there was a detailed, because there was low abdominal pain, blah, 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 hematemesis, etc. So issues of GI was probably fall over there. So review of systems are other systems that you've not primarily reviewed. So in this case, probably respiratory, cardiovascular, skin would probably be there. Now, the other thing I want to point out here, Doc, is healed sutured forehead lacerations. That is more of an examination finding. I stand to be corrected, but skin, like, any previous, because review of systems is what the patient previously had. Were there any skin lesions, neurofibromatosis, skin patches, cafe au lait spots? Those are things that will come up in your review of systems. So also let's be a bit cognizant of what we ask in the history, because that's what the patient knows, and what you will pick up on examination. So that is fine. So I think we can move to your summary. Hello? Oh, yes. Thank you. So summary, I think, was well put. I think it can be a bit more brief, maybe one paragraph, so that we say a 42-year-old FWA, 42-year-old male patient, presented with a 1-week history of headaches, post-road traffic accident, with a prior history of having had lost consciousness approximately 3.5 hours after the injury, with an associated hematemesis and abdominal pain, no focal neurological deficits, or I would say features of raised intracranial pressure, or had features of raised intracranial pressure. The issues of CT scan, barrehole drainage, etc., we can just put it in a sentence, and currently is post-operative, admitted in the unit. So that the issues of CT scan, etc., we'll now discuss them at the end. So summary must be very, very precise. Find a way to summarize everything that the patient has told you. Try to have maybe 4 or 5 sentences that are together. Then after that, you move towards the examination. So I don't know, maybe Saddrudeen, any feedback from the audience before we move on? What do you think about my discussion points?
Thank you for the corrections, Doc. There is a question in the chat box from Abdi Ali. I also wanted to ask the same question. Where do we keep like the scenario of the accident, like the mechanism of injury? Do we describe it before the Socrates of the headache, or do we describe it after? Where do we put the mechanism of injury and the environment?
So mechanism of injury would come in as just immediately prior to the description of the discussion of the Socrates. So you would start with, I would almost call it like a preamble. So it is a patient who has been involved in a road traffic accident 3.5 hours prior, presents with SAWA. Or you can even have, like, if a patient is known to have certain illnesses, for example, FNW, because like, let me give an example. You have patients who are convulsive disorder patients who are more prone to accidents, and they'll probably driving a car and they got a convulsive episode. So it's going to be something along the lines of FNW, a patient who's known to have a seizure disorder, controlled well on medication, presents with a history of having been involved in a road traffic accident after having skipped his medication for a week, and presents with a history of headaches for the last 1 week, presenting like that. So that mechanism of injury would probably come as your preamble, but the cause of illness would come after your important positives and important negatives. I hope I've answered the question well.
Thank you, Doctor.
Okay, excellent. So we can quickly shift gears. We move on to the examination, and then we'll discuss that also.
So in general examination, the patient was sitting upright in bed, alert and oriented to time. He was not in any respiratory distress and appeared comfortable at rest, and he appeared well nourished. So there were 2 healed laceration sites on the forehead that have been sutured, and 2 surgical suture marks on his right parietal region, each approximately 6 centimeters long. IV cannula in situ on the right forearm, but not in use. There was no jaundice, no pallor, no cyanosis or finger clubbing. Capillary refill time was less than 2 seconds, which was normal. There was no peripheral lymphadenopathy. There was no pedal edema and no clinical signs of dehydration. So his vitals, his blood pressure was 128/84. He was normotensive. His respiratory was 15 breaths per minute. He was eupnic. Pulse rate was about 85 beats per minute, which was normal. His SpO2 was 96% on room air, which was normal, and his temperature was normal at 37 degrees. So for his CNS examination, his higher function, the patient is alert. His GCS was 15/15. He was cooperative and oriented to time, place, and person. His memory and speech were intact. So for his cranial nerves, they were intact. There was no evidence of cranial nerves pulses. His pupils were equal, round, and reactive to light. His extraocular movements were full. Muscles movements were full. He had no facial asymmetry, and gag reflex was present. So for his motor system, he had normal bulk and tone in all 4 limbs. Power grade 5/5 in both upper and lower limbs bilaterally. Deep tendon reflexes were normal and symmetrical. The plantar response was flexor bilaterally. So for his sensory system, it was intact in all the dermatomes of the upper and lower limb to pain, temperature, and vibration. So his cerebellar function, there was no dysmetria. He had no intentional tremors, no gait abnormalities, and his speech was normal. So for his respiratory examination, on inspection, the chest was moving symmetrically. It was moving with respiration. There was no use of accessory muscles, no scars or deformities. On palpation, his trachea was central. There was chest expansion, was equal bilaterally. Then there was normal tactile parameters. On percussion, the percussion note was resonant percussion, not over all the lung fields. On auscultation, he had vesicular breath sounds heard bilaterally and no added sounds. So for his cardiovascular examination, on inspection, he had a normoactive precordium. There were no chest deformities, no scars, and no distended neck veins. On palpation, the apex beat was located in the 5th intercostal space, mid-clavicular line, and there was no palpable thrills or any parasternal heave. On auscultation, he had a normal S1 and S2 with a normal pitch. There are no murmurs, rubs, or gallops. Peripheral pulses were present and symmetrical in all limbs. For his abdominal examination, on inspection, his abdomen was flat and moved with respiration. His umbilicus was inverted. There was no visible scars, masses, or distension, and no distended veins. On palpation, his abdomen was soft, non-tender. There were no gynomegalies or palpable masses on both superficial and deep palpation, and there was no rebound tenderness or guarding. The percussion note was tympanic over the whole organs, and there was dullness over the liver and the spleen. Fluid thrill and shifting dullness were both negative. On auscultation, he had normal bowel sounds present, about 4 bowel sounds per minute, and the character was high-pitched with gargling sounds. No breeze had over the abdominal aorta and the renal and the external iliac vessel. There was also no evidence of hernias. For the DRE, it was not done. So my impression was a subacute subdural hematoma because, one, the patient had a history of a high-impact blunt head. Hello?
Just proceed.
Hello, can you hear me?
Then you can continue. I'll join in.
Yes, we can hear you.
Is Doc saying something? I heard him. I wasn't able to hear him clearly. Can you continue?
Yes, Saddrudeen, you can continue.
Okay. So my impression is he had a subacute subdural hematoma because the patient had a history of high impact blunt head trauma. And then there was a delayed onset, the raised intracranial pressure symptoms. And the patient says he had a global headache with visual disturbances appearing days after the initial injury, which is more consistent with a slower progression of a venous bleed rather than an arterial bleed, which presents more acutely. And there is normally a epidural hematomas compared to subdural hematomas.
Okay, thanks, Saddrudeen. Sorry, because I'm also on call. I was receiving a call from the hospital, but I've sorted it out. Before we go, I would like us just to have a brief discussion also here with regards to the examination. Again, very well put. So just let's go to the beginning. Oh, this is the beginning of general exam. So you talked about the condition of the patient, alert oriented in time. So 2 heel laceration sites, that's fine. The length, that is good. So that's fine. So we can move to the next slide. There's a few things I think I had picked up. Okay, these are your vitals, which is quite good. Can move on next. Next, yes. So now here, it's always good to have your Glasgow Coma scale, GCS score, and to break it down. At your level at 6th year, it's expected you know how to summarize the GCS. So, for example, you can have a patient who's a GCS 15/15, you'll just put into bracket I4, verbal 5, motor 6. If it's 14/15, again, then you break down the same thing. It's just lucky that you had a patient right now who was 15, but a good number of times, again, GCS would be much lower than this. So, cranial nerves, I like how you've gone through that. The only thing what I'm not sure about is when you talked about extraocular movements are full, you need to rather use the word intact. Full is not neurological. Then remember, always I've seen students during examination, you tend to forget that there are 2 cranial nerves. There's the left side and there's the right side. So that's something you need to pick up. Motor system, there are 4 things that you look at in the motor, which again has been brought out very clearly. The summary is PBRT. PBRT, that's your power, your bulk, your reflexes, and your tone, which is good. It's good for you to know the differences in terms of the different reflexes that exist. There's what we call superficial reflexes and deep tendon reflexes. Like what you focused here is on the deep tendon reflexes, which has come out well. Next, so that is sensory. Sensory, you need to look at the 2 main tracts. That is going to be your dorsal spinothalamic tracts, and then the lateral spinothalamic tract, I think, which is fine. Then I think cerebellar, you have covered it quite well. The mnemonic for remembering that is dashing. So you are looking at dysdiadochokinesia, ataxia, slurred speech, hypotonia, intention tremors, nystagmus, and any gait abnormalities. So I think that has been also covered quite well. So now, before we move to respiratory, what I wanted to just ask, because there was that history of hematemesis, etc. How was that, by the way, taken care of in the course of illness? Because I don't think that came out well.
He had just I wasn't able to get the exact details from the file. His file wasn't updated, but at St. Peter's, what the doctor wrote was possibly nasogastric decompression. I mean, a decompression with a nasogastric tube.
Okay.
the bleeding, but then it resolved and he did not lose a lot of blood.
Okay, no problem. That's fine. It's not the primary focus of our discussion today, but still it's in a patient who had traumatic brain injury. So it's also good that it comes up. Whenever you finish your CNS exam, then you go to the next second most important. In our scenario here, it was abdominal, per abdomen. So because there was also some injury that had occurred there. So that's how I want you guys to place it. I think this has been done quite well, which is fine. I won't belabor the point here. Respiratory, I think, was also covered well, and CNS was covered, CBS was covered well. Now, I want us to move to your formulation because impression. Now, there is no way that you can be able to have a diagnosis of a subdural hematoma from a patient which you have done the history and the physical examination. I want that to come out clearly because you'll be told based on what. Now, when you are making an impression for this particular patient, number one is that you have a patient who has been involved in a road traffic accident with a history of loss of consciousness, currently presenting with a GCS of 15/15. So if a patient comes to you like that in casualty or in the ward like what we have right now, there's a chance that that patient could have had GCS that was lower at that particular moment when they presented, and now they're better, like in this patient post-operatively, or you have a patient who came in with a GCS of 15/15. Now, we do not know the presenting GCS of the patient at that time when they came in because we do not have an informant that was there, but we have the history of the patient and we have the patient's current status. Now, what you can make an impression of is we need to make an impression of a patient who has come in with a head injury. That is what you can make an impression of based on the history and physical exam without looking at the images. Now you need to classify further the level of head injury. Is it mild head injury, which is GCS of, 14 and 15? And then you talk about moderate head injury in between 8 to 12. Mild is 13 to 15. 8 to 12 is going to be moderate. 3 to 8 is going to be severe head injury. That is what you can make a diagnosis of a patient for. Like in this particular scenario, patient also had other injuries. So it's a patient, you can also say a patient who is a polytrauma patient with features of mild head injury as evidenced by the Glasgow Coma scale of 15/15 and a preceding history of a road traffic accident and a GI injury, a gastrointestinal injury, as evidenced by hematemesis. The take-home message, ladies and gentlemen, I want to put across here is a diagnosis of a subacute subdural hematoma cannot be made only from the history and the physical exam. That is where people are caught up in the exams. Now, the next thing that you come up with, which is your impression, as Dr. has put up for us, is what are your possible differential diagnoses? What are your possible differential diagnoses? So with regards to differential diagnosis, now that is what you suspect from the history and physical examination. So in a patient who has come in with a mild head injury or a head injury post-road traffic accident, 1 week down the line, you could have a patient who could have got a subacute subdural hematoma. You could have a patient who has got a chronic subdural hematoma, a patient who could be having a resolving epidural hematoma, a patient who could have had a resolving intracerebral hemorrhage. So are you seeing, Saddrudeen, how I'm trying to bring up the differentials versus what your impression is? So my point is start broad, because you cannot see inside the brain to know what is a subdural hematoma. Now, what will confirm for you your diagnosis is what you see on the scan. So you have a suspicion, for sure you know that this patient has got a head injury. You're sure about that. Why? They presented with loss of consciousness, worsening headaches, GCS was 14 or 15, whatever it is that the patient came in with, and a head injury, whether mild, moderate, whatever, you can even go ahead and say as evidenced by, which I've been able to tell you. Then from that point, which is your impression, their differential diagnosis. You can be told, give me 3 top differential diagnoses that you can have for this patient. Now, the issues of subacute subdural hematoma, at that particular point, it's a suspicion. So you can say differential diagnosis of 1, 2, 3, with my top differential most likely being a subacute subdural hematoma. Why? Because of the time of presentation that the patient has come with. Sorry? Are we together? Can you hear me?
Yes, Doc, we can hear you.
Oh, thank you. Sorry, because I had some background noise. So then you say my top differential probably would be a subacute subdural hematoma. Why? My suspicion because of the duration of time that the patient has come with that and the worsening symptoms of the headache that the patient has. But you cannot confirm that unless you see the scan. So that is the take-home message that I want to go home tonight from this particular meeting. Sawa? Good. I hope I'm making sense. Saddrudeen, you're the main presenter. Am I making sense to you? Or I'm confused guys more?
No, you have clarified it very well.
Yes, because we cannot make a diagnosis of a subacute subdural hematoma from the history and physical exam. You know, you are lucky, you've already gone, you've seen everything, you've seen the scans, etc. But the scans are confirmatory. What you are sure is what you have on your history and your physical examination. Same thing, like for example, in abdominal exam, you can have a patient who comes in, they have severe abdominal pain. They probably would have, the impression would be intestinal obstruction. Then from your intestinal obstruction, most likely you can say something like fecal impaction, you can say diverticulitis, you could say a volvulus, but you cannot tell those particular diagnoses just from a physical history and examination. So your imaging and your scans will be able to help you confirm. It's the same thing with the brain. So whenever you have a patient with traumatic brain injury, your broad impression would be head injury, classified, is it mild, moderate, severe, based on the GCS score of the patient, and what makes you suspect that the patient had a head injury, the preceding mechanism. You can talk about the loss of consciousness, the headaches, then from there, give your differential diagnosis. Sawa. I hope I'm clear. If you have any questions, let's see. Let me see the chat box. When presenting an already recovered patient, how do you go about it? Exactly the same way that Dr. Saddrudeen has gone through it. You talk about what you find at that particular time. But you will also give us the cause of illness, which is what the patient had presented earlier with, and that one will be corroborated by your informant, in this case, a relative or whoever it is. So I hope I've answered Dr. Omar. Dr. Bonica is asking, in the ROS, are we inquiring about current systemic complaints in other systems, or what other systemic complaints were prior to admission? Actually, it's both, because you're reviewing systems. So if a patient had got a history of asthma from before, in the review of systems, it's coming out, or any other illness that they had prior. Then you have any other injury that probably is not significant enough that didn't come out in your major complaints, then that would be relegated to your review of systems. If someone had got significant injury like a hemothorax, which we get patients in Kenyatta, together with a head injury, then all those are going to be elevated to be part of your main history taking rather than the review of systems. So Buanika, I hope I've answered you. Hirsi is asking, I would like to know about how to analyze convulsions in the HPI. So convulsions, I want you guys to divide it into 3 phases. 3 phases means pre-ictal. Pre-ictal means before the event. So pre-ictal patients would have, depending on where the convulsion would be arising from, a patient would come in, they would feel either a sense of impending doom. They would tell you that I get severe headaches before I start seeing bright flashing lights. So you need to ask the pre-ictal phase, what happens before the ictus. Then describe the ictus. The ictus, you'll describe how long it has lasted. That's 1. 2 is issues of, is there a witness to it? Is it a generalized tonic-clonic convulsion, or it's partial seizures? Those are things that you will bring up. in that particular scenario. Then post-ictal phase means after the end of the convulsion, what happens? Does the patient sleep? Does the patient urinate on themselves? Does the patient act confused? Those are the things that will come up. So whenever discussing convulsions, I would like you guys to divide it into those three phases. So I hope I've answered you, Dr. Hirsi. Risk factors, Songok is asking, where do they go in the neuro exam? So risk factors would come up in the history after your immediate, you've asked about your, what are they called? Your positives and your negatives. So in your negative risk factors, you'll have some risk factors over there for the patient, like any alcohol intoxication, which is a risk factor for this patient in terms of getting an accident. You would put it there in your important positives, and then you rule them out if it was a risk factor that a patient has or might lead them to have a road traffic accident, then, and they did not have that particular risk factor, like this patient was not driving when drunk, then you put it in your negative risk or your negative, important negatives, what we call important negatives. So remember how I told you, biodata, you have your chief complaint, you break down your chief complaints, each of them, then you have your important positives, then you have your important negatives. So in your important positives and important negatives, you rule in or rule out various different risk factors that you have. Okay, so I think SRG, where do you keep the scenario of the accident? Is it before? Okay, I think I answered that. Okay, so I think I've answered all the questions. Then SRG is asking traumatic brain injury classified based on the current GCS score in the ward of the one. Okay, so if you have someone who corroborated your history for you at the time of presentation, you'd be able to tell. Obviously, if it's someone who's a lay person, they cannot tell you, but they'll tell you something along the lines of alikuwa hata haongei. So you'll say there was a low GCS. So at that particular point, you can say a patient who had severe head injury. If you're not able to get the GCS score, then you will just leave it broad spectrum as head injury, post-road traffic accident. That is your impression. If you're able to get someone who's able to tell you the GCS, for example, the informant is a healthcare practitioner, then you can be able to classify your GCS. So your impression is essentially based at the time of admission, right? But right now, because the patient has got better, you cannot say that the patient has got mild head injury. But if you're not able to get the GCS score of the patient at admission, my advice to you would be leave it broad spectrum and say it's a patient who had got a head injury, post-road traffic accident, or a polytrauma patient with head injury and abdominal injury, post-road traffic accident. That's your broad impression. Then you give your differentials. I hope I've answered you, SRG. Good. Awesome. So I think we're doing well. Good. I think we can continue.
So for his investigations, his was normal apart from the chloride that was just a little bit low. And for his full blood count, it was overall normal full blood count. There's no evidence of any infection, anemia, or thrombocytopenia, and red blood cells, white blood cells, and platelets within the normal ranges. So this is his head CT scan. It's an unconscious head CT on the. It's an axial cut, and it didn't have a report, but I was able to elicit first of all the arrow on the right here. I was unable to appreciate some kind of gyrine, which maybe led me to suspect some form of cerebral edema, and then drawing a line to the center, through the center. Ideally, they should be mirror images of each other, and we can see that the ventricle on the right is slightly pushed towards the left side to indicate a mass effect, and there was a hyperdense lesion on the right parietal region. So this is the same CT scan on coronal, the same non-contact CT on a coronal cut. I was able to also appreciate the same mass effect and some cerebral edema, intracerebral edema. So I think that was all. and his current management plan.
So can we discuss the scan so that people also get some few things on the scan? So again, I think we'll probably, it's not fair to discuss scan only in this session. So I would want you to have the team organizing maybe one discussion evening similar to this one. Then I'll take you through at least how to do a discussion for a head CT in detail. So there are a number of things that you must always say when discussing this particular scenario, especially if you get a CT scan in an OSCE station. Reason being is that you first have to talk about the biodata of the patient, XYZ, done on this date, in this patient with this, and if it tallies. Then you have to talk about the cut, which I think you brought out well. This is an axial cut. You need to talk about what window this is. So this is a brain window. Then you need to discuss what level of the cut it is. So like the one that is in red where the arrow is pointing at the level of the lateral ventricles. You can be able to see. Then you need to talk about there's obvious midline shift with features of loss of gyri and sulci. The midline shift is towards the left side, and there's a crescenteric iso to slightly hyperdense lesion on the right that is causing the mass effect with several contusions that are there. So that is what I wanted to come out. So you talk about the side, the site, the shape, the density relative to the surrounding brain, the shifting of the midline. You discuss about issues of the like most likely this is a patient, there's even what we call subfalcine herniation because part of the brain is being pushed under the falx cerebri. So there's a lot we can discuss here in the CT scan. I don't think we will have done justice to it tonight. So maybe the team can organize another session just for discussion of imaging of the brain. We can, just go through the specific areas, go through different scans, and then I can show you the different presentation in terms of epidural, subdural, intracerebral hemorrhage. Like even this one, if you see closely, there's a part of it whereby the bone is involved. So there could be a linear fracture that you can be able to see. So all those are things that I want you to come up with. And there's a subgaleal component that is there. But overall, I think it's good. So, but we can have a longer discussion on another evening because I can see time is almost up. So let's continue.
So lastly, his management plan, his post-op instructions were to do neurological monitoring for him hourly, vital monitoring for hourly, change of dressing on the surgical site on post-op day 3, and removal of sutures post-op day 10. His current discharge instructions include taking acetaminophen 1 gram 3 times a day as needed, and levotiracetam 500 milligrams twice a day for 7 days for seizure prophylaxis, and patient education on the red flags for worsening headache and signs of elevated intracranial pressure. And he's scheduled to be followed up at the outpatient clinic after 1 week. I think that is the end of my presentation.
Thank you very much. The commonest question I've seen, especially in the long case for you, especially because, post-operatively, it's more of now our level. We're the ones who are operating. How do you manage a patient post-op? For you guys is you are the medical officer at a hospital, maybe say in Tigoni, and this patient presents to you. How would you manage the patient? So the answer to that is ATLS. You must know your ATLS. Ensure, because this is a patient who has been involved in polytrauma, so don't think only of the brain at that particular point. For what the consultants wants them to come up in that particular scenario is especially with regards to the different management protocol. What saves the life of the patient? Because you guys, in 1 or 2 months, you will finish and then you'll become the first line doctors in the country, in casualty, in the ward, wherever it is. So what is going to give you that chance or what is going to give that patient a chance to live and survive, that they don't die in your hands. Mambos are postoperative, etc. Rarely will you be asked about, or they might ask you like a broad question, would you do a bar hole? Would you do a craniotomy? But that's for a neurosurgical resident, in all honesty. For you guys is acute management. ATLS is a must know, especially in a surgical exam. I am not going to ask you about steps of doing a craniotomy. Well, you don't know about an ATLS. So my advice to you will be in terms of management, any management question that you get, and you will tell me, you will be with me in the next 2 weeks, 3 weeks, please give me feedback and tell me if I'm lying. You will be asked about immediate management in the casualty setting. Why? Because the consultants are preparing you to be the first line point of contact when such a patient comes to you. So ATLS, my dear friends, is a must know, and must is in capital. Make sure you know how to manage the airway, how to sort out breathing, how to sort out the C circulation, disability, the GCS, etc. If a patient has got a spinal fracture, what would you do for the patient? They're expecting you to talk about things like putting the patient on a flat board, putting the patient on a collar, how do you intubate a patient who is on a collar, you know, those head lift, chin thrust, whatever it is. Those are the most important things for you at your level. So that is what I really, really want to come up in management of this patient who are especially prone to head injury. For you guys in your long case, there's a very good chance that some of you will also get patients who have got head injury. Most commonly, mild head injury will be able to give you a good history. Then after that, you'll be asked questions in terms of this. But overall, I think in my assessment, it was a very good session, very well prepared by Dr. Saddrudeen. I think he deserves a clap. For the team that organized this, thank you very much for giving me the opportunity. For everyone who attended, I hope the session was useful and I was able to give you a few, areas to check on and be clarified on. Then I think my recommendation is organize another session for scans. We'll discuss scans, take a few pictures, look for epidural, etc. We'll describe them, and then you'll also be good. So basically, issues of neuro, we'll have gone through history, physical exam, imaging, and management. I think we'll have done that. Thank you very much.
Thank you so much, Doc, and thank you everyone for attending. I think now I'll leave it to Khalid, the head of the academics department, moderating the session.
Thank you all for being with us this evening. A big thanks to Saddrudeen for the solid presentation and for Dr. Mohamed for walking us through the discussion. To all of you who joined us, also we thank you for your attention and questions and your curiosity. On behalf of the committee from MSAUN-KNH, we once again thank you for joining us this evening, and we look ahead for the other session. And Doc, inshallah, we'll be in contact to organize the session on imaging. And we should close with the dua. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت استغفرك وأتوب إليك.